So, welcome to NUR203 Pediatric Nursing. Yes, we have a big class today. I was explaining a couple times, but those who didn't hear, Professor Gaux's father had a medical emergency, and he had to fly out, of course, to be with his father, just like I would be if anything happened. So he will be giving you information and announcements, what you need to do, and for further classes, etc. Know that I am always here. Any questions, please send them to me for the first week. Let's give him the time he needs to take care of his father. That's what nurses do, right? We take care of our family members, and that's what he needs to do. So, any questions, please just send them to me. And I'm going to go over my email. I'm going to go over my telephone, my cell phone, all of that. You can get a hold of me anyway. So, pediatric nursing is an interesting course. And a lot of people think it's just another course. It's not like a med surge, too. Well, I'm going to warn you right now. Pediatrics is a high level med surge 2 course. And you're going to see a lot of similarities between med surge and pediatrics doing the same topics almost at the same time. I've actually been told that the way that I describe things helps them in med surge. So, yeah, med surge for many adults. But remember, they're still kids. There's a lot of kid stuff in there that we have to remember about it. Thank you. That's a great thing. Because there's a saying that pediatrics is not little adults. They're their own little human, and they act in different ways than do adults do. So we'll be getting to all of that. So first of all, make sure everybody puts your name and campus in the chat box in case I have to get a hold of you. So today, what we have to go to do is we're going to go over our orientation PowerPoint online. You saw one last term in OB. I have mine, and I've added some extra stuff that Dr. Brown wanted there. Also, we're going to be doing a PowerPoint for week 1. It is actually 5 chapters, 26 through 30 through 30. So there's a lot of chapters with it, a lot of information, but a lot of global information, and you'll understand that as we go over it. And then just to test you all on what you've learned today, I have a Kahoots every single class. Now, last term I did something because a student suggested it. And she suggested that I take every chapter and at the end of each chapter to give a Kahoots, which means you're immediately tested on that information. Now, this week I don't do that because it's a global type information. But starting next week, when you do infants, toddlers, and preschoolers, there's going to be there's 2 Kahoots next week. I combine the toddlers and the preschoolers. Infants are a world unto their own, and you're going to understand they can't lift their head up. Until 1 year old, they're running around and talking and eating by themselves. I think that's just amazing how quickly that first year of life goes. But you can imagine all the growth and development that we have to understand to say, is that child acting normally? Or do we need to get some early intervention and get that child where they need to be, whether it's speech, physical, occupational therapy? So again, I'll be giving those Kahoots at the end of every class. Now, what I usually do is run straight through class and let you out early. Does anybody have a problem with that in my class? Usually you don't.
Absolutely
No.
not.
So you get 10 minutes per hour. So we're almost 3 hours. So there's 30 minutes. So I will usually get you out by 4:30 Eastern time because your class goes to 4:57 Eastern. So it gives you right there what you need to do. So that would be my goal for my class, to get you out a little bit early. I know that's what you usually like to do. Now, if you need to eat, I get it. I understand. Please have something to eat, but just do it without dribbling all over, one of those type things, be nice and polite. I don't care if you have, a soda or a tea or something to drink, not a problem. I always have my bucket of water right next to me, not a problem. Um, Dress, you can dress just comfortably, but please not in PJs and nothing that everything sort of hangs out. And that happens when the summer comes. So right now, everybody is bundled up, and I understand it is winter, although I think it's about 70 degrees where I live. I live in South Florida. Um, I live in Homestead, which is right above the Florida Keys. So my weather is pretty temperate all year long. It did get down into the high 50s last night. So for me, that was cold. And I'm sorry, because I know most of you live in places that are very cold. So let's go ahead and let's start today. Any questions about anything? We're going to go into how to get a hold of me. Know that in the modules about Professor Bogart, you're going to have my cell number, you have my Zoom number, any information. Again, it's in the announcements. There's my Zoom number on how to get a hold of me. Okay, so whatever you need, just let me know and I can help you.
Miss Bogart, I have messaged you in the chat, but Hannah's trying to get in. She didn't
Okay,
see the announcement. She was sitting in the
I'm
other
in.
at our professors.
I'm in
I,
now.
I,
Yeah.
Okay.
there you are. Thank you, Hannah. Nice to
Yeah.
see you.
Yeah, sorry. I was waiting in that other one for like 25 minutes and I was like, something's not right.
Good job. This is what nursing is all about, helping each other and keeping each other safe and, speaking up for each other. Can you imagine in a code situation by yourself? Not going to happen. We're a team, and that's what nursing is, and that's what you should always promote. It's no cliques. There's no cliques in nursing. It's all a big team, and we all work together, and that's why I love nursing. So online nursing, it's different. So you do all the things on campus. You have your sim lab, you have your clinicals off, it's not on Zoom, it's in a clinical site. And you have me, which is going to be teaching you the concepts and the didactic portion to try to understand what you're doing in those simulations and the clinicals. Now, I did teach simulations on ground. So I know exactly what simulations you're going to do. And I know the areas of weakness. So because of that, I know what areas to cover pretty intensely with you. Mostly cardiac and respiratory, to tell you the truth. Those are always the hardest. So let's say you all are having a problem. You don't understand an assignment. First of all, you always contact me, whether it is on my cell phone, I'll give that to you in a second, or email or a message in Canvas. Now, if you're contacting me on my cell phone, that's an emergency. That means you're sitting down, you have 3 hours to work, and you really like an answer because really want to get that assignment done now. That would be for me an emergency. Okay, text me and I can get you a message back quickly. But also know that I've got email and whatnot on my phone. I'm always checking it. I'm a little bit OCD about it. And I check up to the point almost where I go to bed and from the moment I wake up in the morning. So rarely are you guys going to be without me being able to contact you. Now, if something happens and you can't get a hold of me, you always can go to Dr. Brown. Now, I am the lead pediatric professor, so Professor Gaux's students, you can always reach out to me. I'm always here for any pediatric student. Doesn't matter the PN, the RN, doesn't matter. I am pediatrics and I will help anybody with it. Now, if I can't help you, and here's my cell phone there, it's 305 951 8055. You can always contact Dr. Brown. I do not get bothered, upset, mad, want vengeance and meanness. No, please, if you need something, I can't give it to you. Please contact Dr. Brown. I don't get yelled at. I'm not going to be getting demerits. It's not like that. We are here as a team. We work together. And when I can't, she can. And when she can't, I can. So we work together like that. Okay. And there is her phone also. Leave a message. I don't think the woman ever sleeps. She'll get back to you soon also. So when you're communicating, the one thing that we do request is you be courteous and positive and all those good things. No big capital letters when you're trying to say something in big, I really don't get this. You know, I understand that, but just be very professional. Remember, you're going to be nurses. That is a registered professional nurse, and we do things always in a professional manner. We do have start time at 2 o'clock for class. At 2:01, you will be 15 minutes late. At 2:16, you are 30 minutes late. Just to remember that for future, because attendance, I know you miss here and there a little bit. It does add up very, very quickly. And you will get all of those notices and you know them all about. Now, this week, you have a discussion board question. The first part is due on Wednesday. This week, I don't put the Wednesday detail in there because I know there's movement, there's things going on, etc. So as long as your discussion post is in by Sunday with 2 peer responses by Sunday night, we're doing okay. All right. Know that the first discussion question, it's 2 parts. There's one part of tell me about you, but the second part's about nutrition. And nutrition. If you don't have nutrition, children are not going to grow. They're not going to think. They're not going to be that wonderful child they want you to be. They want you to be, unless they have proper nutrition. So answer that part of the question, okay? If you've already answered the discussion question, you can always send in another part of it, and I'll accept that. Know that we do look for academic integrity and not to cheat and not to plagiarize, not to forge assignments. Fortis is really into understanding all those websites that are out there that you can use. I mean, I know the stuff's out there. Just don't copy and paste it. And is it a scholarly source? Are you really copying and pasting information that's accurate? That's the point that I am concerned about. There's a lot of stuff out there. Use your own words, and you're going to need that when you do your pediatric assessment project, which is due for week 8. Know that if you were here last term, your stuff is now plagiarized if you turn it in again. You have to reword it. That's one of the things that I see all the time where they just turned in the same pediatric assessment assignment or same discussion questions, and it comes up that it's plagiarized. It's plagiarized by yourself because you turned it in once, okay? And it's something I know Dr. Brown is a stickler about, just to give you heads up so you're not doing any double work, okay? Know that we know AI is out there and it helps you write. Just know that we have to know what is approved, what's not. So let us know what you're using so that we can make sure that it's done in a proper way, okay? Code of ethics, is just being the most professional person that you can be and living up to ethical standards. I think probably the biggest one here is not just copying and pasting and cheating from sites and other people, etc. It's also during quizzes, trying to go out of the program and to look at other websites and get answers. We can see every time you click on the computer. We know when you are out of that screen, when you come back in that screen. So just don't do it. Just do the best you can do on all the quizzes, okay? Because I'm not going to sit there and go crazy doing 360s on a quiz. I only do that for our exams. Again, those promoting, those cheating, we know where they are. There's some examples here, all right, where we know that they are. Now, note that if you are caught in a plagiarism thing, we will reach out to you first. Tell me about the paper, the this, the that, whatever it is. And then you tell us what your answer is, and then we'll make a decision from that. Is it plagiarized or was it some other variable that we're starting to learn about that goes on, okay? So again, we're not going to immediately give you a 0. No, we're going to let you redo it. But if it happens again, then we consider it plagiarism and then a write-up will incur with it. So just be aware, okay? So I have put in every due date, every advance, that week later date on all the assignments for every single assignment in there. Know that if you get your homework in on the week due by Sunday, 11:59 p.m. Eastern, you'll get full credit. If it's after that, and you have not told me you're going to be late for whatever reason, it will be, you have one more week to get it done with a 10% deduction. Now, let's say all of a sudden your boyfriend, your husband, your daughter, your dog, or whatever, had to have all of a sudden medical care or something happened and you couldn't get something done because of all of this stuff. Well, before that assignment's due, send me a message. Hey, my daughter got really sick. I haven't been able to sleep. Please, can I have another day to finish my assignment? And I will absolutely give you that extra day. I understand those things happen. As long as it isn't every single assignment. But here and there, I understand that happens. Life shows up to me too. So I get it. I understand it. Last term, what showed up in my life? We had a hurricane and I was in Jamaica during that. So that was my life show up last term. Yes, I was there for Melissa. And yes, it was pretty scary. And thank goodness I was in Kingston and I was far east of the hurricane. So I get it. Things showing up, you can't come in. And I notified all of you 3 days before it all happened because I knew it was coming. So again, just tell me before and everything is good. Now, attendance in online courses. Now, you're going to see how that professor last term on week 12 was like, you got to show up for class for 30 minutes. You got to be here. And it's all about attendance, right? Yeah. Well, what if you missed this week's class and you didn't go to week 12's class? You are now 14 days without showing up. You can be dropped from the program. That's why we are like, you have to show up. It's 30 minutes. It's your attendance. Please be there. Because we know the first week stuff happens all the time where, you didn't get into a class and now you're 14 days without sitting for a class. You can be dropped. So attendance, very important. Like I said, be to class on time at 2 o'clock. You're on time. At 2:01, you're 15 minutes late. And know that Dr. Brown and her assistant, Deborah Northrop, do send you notes that'll tell you your 5% attendance miss, your 10%, your 15%. I'll also be telling you, hey, you're getting close. Please don't be late. What's going on? And you can't make up attendance for any reason. The only time you make up attendance is this week, where maybe you're not in this class and move to another, but you already got this attendance in. That's the only time. There's no more times we make up missed attendance. As I said, please come, do your professional, be professional and clean. Don't be in jammies. And, again, those revealing clothes, like I said, that's usually again in the summer. Again, attendance, I've already discussed about it. I've already told you you're going to get all of these letters that are going to come through. And this is a new slide we put on this term. Making sure that you don't have an inappropriate use of legal substances like vaping, tobacco, marijuana, the edibles in the tolerant states, alcohol, and some medications. Know that anything that you take that's not deemed appropriate, you need a prescription for. And the Dean of Nursing needs to know any medications you're on that could alter your mental status. That's what this is talking about, okay? Even vaping, just tobacco. I've had students on screen do it. You cannot. You wouldn't do that in a classroom. You're not going to do that on screen, just so that we're aware of those things. Okay. And the other thing that we're talking about is that, doing these things in public and being a nursing student, what are you portraying to your surroundings and the people? We want to always keep nursing a professional thing. So being successful. Every week you're going to get an announcement. So I don't send 100,000 announcements. I don't think it does anybody any good because you're not going to read them. I send one out at the beginning of the week that will say something like week one information. Well, mine this week said, welcome to NUR203 Pediatric Nursing. That is your announcement. On that, we'll have your PowerPoints that will be there. It'll be any handout information. I have sent out to my students and also Professor Gaux, I'm going to send it in the recording I send you after class today. You're going to get week one matching, which is a great thing to go and do it, and the answers are all there. You're going to be getting vital signs on children. They're all different ages. I mean, a neonate at birth, heart rate's 140 to 160 at sleep, and it's perfectly normal. Not for an adult, right? So again, vital signs will be there. Also, we're going to be getting into theorists. Your theorists are going to be there, a nice little handout on it, and I'm going to try to explain it to you, okay? So those are guides. They are there to help you. Use them. I have made things for cardiac, for respiratory, for GI, GU. These are tools to help you, where I'm putting the concepts in there that you need to understand to be able to take quizzes, to take exams, to take your essay. All that information is there. Make sure that, the assignments that you're going to see, these are the assignments that are due, that you get them done and you get them done on time. Remember, your syllabus is always your Bible. The only change that's going to be on that syllabus is you are not going to have a quiz week 3 because it is Martin Luther King, isn't it, that week? And we don't have class. Monday doesn't have class on Martin Luther King Day. That's that Monday in 2 weeks. So there is no quiz that week. We're going to put it into week 4, into the exam, put it all into one, okay? That's already been planned for the future. Know that whenever you're doing your assignment, please just get the best grade you can. It's very frustrating to have a student pass the KGA, your exams, your quizzes, your HESI, and then fail because your homework wasn't done well enough. Please don't do that. Get a 78 minimum. I mean, many of you get the 100, which is awesome, but please just don't do that. Give it at least a 78, and that will make sure that once you do your KGA and get it good, you're going to be able to pass the course when we add in that KGA, okay? Again, always contact me for anything, any questions. Now, you have my cell phone and you have my Canvas. Please send me any message you need. It would be nice if you came to class and that you have looked forward and looked at the information. And I'll tell you why I say that. I have found that in nursing, that if you are someone who read the stuff, so you got a little bit of knowledge before you came to class, and then listened to lecture, that's number 2 times now that you have listened to this information. And now I'm giving you a cahoots. That's 3 times these big concepts that you need to know have been done and repeated and repeated. You're going to remember it better. Especially if you come into class like, I really don't get this. I wonder what that's all about. And then listen to it carefully. Or go back to the recording and listen to it carefully. Whatever it is, that's how you have to take care of you, your knowledge, and to making sure you're understanding. Now, I don't do per se weekly tutorings. What I say is, if you need me, I'll come before class, I'll stay after class, I'll come at another time. You have just got to come to ask me, and I will set up a time that's good for you. Okay. And I will work very closely with you. We will have exam reviews. As I said, I make them, and you'll be getting them at the end of week 3. You'll be getting the exam reviews, times, and you'll be getting the review PowerPoint to use to study. those students who are repeat or are re-entries, please contact me. We really need to set up tutoring so I can get you through this course. You're not going to go through this course again. We need to get it done and we need to do it right. So again, I know that if you come to me and I can help you, and I don't need 2 hours every week, give me 30 minutes. I'd be happy. 15 minutes is it, whatever. And I know your time is very precious. Whatever I can get, I will help you with that. So as I mentioned, KGA and your homework grades. Your KGA is your unit exam, quizzes, and your specialty exam. And that's 80% of your grade. When that is done, we're going to add in homework. And you could see how it all adds up. Now, the big things of homework, your NCLEX are 5%. The case studies, those SIMs that you don't really care for that I've heard of, they're 6%. And then there is a big assignment due week 8. It's called a pediatric assessment assignment. It is a 3-part assignment. Yes, Julie, you have a question?
If they're struggling with the SIM chart, because last time for me it was the first time we've done them, and it wasn't really explained to us. But I got a video from one of our associate deans on how to do them. So if anybody in the class needs that, I can forward that video to them.
Julie, send it to me and I'll
Yes,
send it to
send it to me
everybody.
too. Yeah.
That would be
Okay,
awesome. I would
okay.
totally appreciate that. Thank you.
You're welcome.
I love it. Beautiful. Thank you so much. Because I know it was last term, it was the first time out and students struggled with them. So any help is going to help you. So that's awesome. So that pediatric assessment assignment, start thinking about a pediatric diagnosis. It could be something you had, your child had, your next door neighbor, your aunt, your uncle, a friend, somebody, an acquaintance, something you saw in a hospital, something, a diagnosis you want to learn about. That is pediatric. And almost everything can be pediatric, except a myocardial infarction. That's usually, we wouldn't put that in the adult world, but congestive failure, heart failure, that could be a child, right? But so anyway, start thinking, what do you want to learn about? And if you think about something that's close to home, something you want to learn more, you're going to get more out of the assignment. It's not going to feel like such a chore. And if you need understanding, go to Module 8. It's 3 parts, a paper. There is a handout. It's quite extensive. And then number 3 is a teaching. Teach me something about this diagnosis. Is it diabetes? Tell me how to give an insulin injection, or how to do a blood sugar, or how to eat, how to count carbs, all of those things. Those could all be a teaching. ADHD, how to be organized, how to put your study places. Anything can be taught. So again, that's the thing to look forward to. Again, as you get a diagnosis, send it to me. Let me approve it. That's the only thing. I have to approve it. So we turn homework grades on and off. And why do we do that? Well, we turn them on and off because right now they're off. That means all you're going to see is KGA, which is just your quizzes and your exams. So you're really not going to see anything till after next week, because next week is your first quiz on this week's information. Okay. At week 6, we turn it on because now you've had NCLEX questions, SIM charts, you've had all of these homework stuff in. And you're going to see how, if you didn't do well on them or didn't turn them in, how it really will affect your overall grade. And that's why we turn them off and on. Now, week 8, we turn them off, and they are not going to be turned on till the very, very end, and that's your final grade. Okay. So you need a 78 on KGA. And then you could add in your homework. And after the homework, if it's still a 78 or higher, you pass the course. Know that for exams, I don't put you on two devices for a quiz, okay? I do my own check, my own way. I'll look at your ears, your wrists, I put you, I'll pin you, whatever I got to do to watch you. I will watch you during a quiz, but I do not do it on two devices. On exams, absolutely, you need two devices. Also, the one thing that students forget is their charger. Make sure everything is well charged or you have a charger on them. Don't let the dog eat it. Don't forget it at your friend's house or the husband has it in the car. I've heard all things about these chargers, okay? Make sure you have one. As in those quizzes, we've already talked a little bit about it and we're going to be doing my little check before. Now, I make the quizzes too. They are 10 questions and it's 15 minutes and you can only go forward. You can't go backwards. And what I do is I make a quiz bank and I send it to all of the professors and they could choose whatever questions they want from them. There's 30, 40 questions. So everybody's is a little different, but on the same concepts, okay? They're all very similar. Now, quizzes cannot be made up for any reason unless it's the end of the term, you have a quiz and it could help you pass. If you have a valid excuse with documentation, a doctor's visit, something about the electric company, the internet went off, or anything, or a car accident, show me the report, the date, the time, shows it the date of the quiz. Those times, with an appeal, they might let you take the quiz. May or may not, okay? Remember, quizzes, exams, you must be on camera at all times, as in your face can't go off to the side like I see all the time. Whole face on camera. And if not, I'll be sending you messages. Your exams will be through ExamSoft. We don't get access to them till next week, and I'll be putting up one of those exams that you could go and practice on, okay, just to make sure that your ExamSoft works, et cetera, et cetera. So look forward to that. Know that exams, let's say in the middle of the exam, your power cuts off, your internet goes, your screen turns black, and you are on question 22 on the exam. What do? You take your phone, you text me, and you say, my computer just turned black. And I'm going to tell you, don't touch it. Don't go back to the exam. Leave it. Go fix your computer. Come back to me. We'll make another time. I can get that same exam started up from the same place that your computer went black or it went off. Okay? If your internet's not working right and it's coming in and out and you're not getting good internet service, go off. Don't take your exam like that. That's too much stress. Stop. Send me a message. Stop taking the exam. I can always set it up at another time. Do you understand that? I don't want you to do things under due stress. I want you to take things when you're relaxed, as you can be, of course, without all those other things going on. If there's a problem, technical, stop it. Let me know. I can always get your exam started from where you left off, okay? Anybody with accommodations, I need to have that before exam one. Also, I will send it also to Dr. Brown. This will give you the extra time on exams, but it gives you extra time on quizzes. So I need it before next Monday for anybody who does have accommodations, okay? Exams are always during class time. I start off with the exam and there's always a class after the exams, okay? Always a class after those exams, all right? So if you all of a sudden can't get to the exam for whatever reason, I've had students wake up with GI bug and they can't keep their head out of the bathroom, or they had to run to the ER, or their mother had a heart attack, or I mean, I could go on and on and on. Let me know right before, and I can reschedule your exam. Don't not just show up and expect me to take the, oh, well, my mother went rushed to the hospital. Text me a quick message. You can always have your phone next to you. Hey, my mother went to the hospital. I'm not coming in for the test. I'll call you when I can. That's it. I don't need any more than that. All right. And then I'll ask you, give me something from your mother that shows me documentation. That just proves that, yes, there was a problem. Yes, it's validated. You can take the exam at another time. It has to be within 1 week. So you would have to take it by Friday or by Sunday if we can arrange it on the weekend. Okay. If you want your campus done, your exam done on campus, I don't have a problem with that. I have one campus that always does, and you know who you are. Just have that person notify me 72 hours in advance. But you also, the student, have to notify me. I'm going to be taking my test on my exam on campus with such and such. It has to be same day, same time. Okay? Not a problem. I will send them a code. I make an extra exam for y'all. You've got it and it's yours. I have no problem doing that, but make sure you follow procedure. You tell me and the whoever's proctoring. I have to make sure the proctor is a person who should be proctoring. Yes, all exams are Zoom proctored that aren't on campus. And I'm going to be asking for an ID, school ID, or your license is okay with me. And I'm going to look for ears. I'm going to look for, stuff around 360 views and whatnot. Those with accommodations, we have to figure out when you're going to take those exams, or do you want to take it with class? Do you want to come early? What do you want? I'll work with you, any of you who have accommodations. The one thing I see is no hats on the head, and ears need to be open and uncovered, okay, during exams. As in missed exams, you didn't call me, you didn't tell me, you just didn't show up. You will get a 10% deduction. And you have to take it within 1 week of class, which means you, by Sunday, you're going to have to take that exam. Has to be before class or Monday morning before class. It must be done that way, okay? And one thing we've heard a lot is students, they want to repeat the exam for whatever reason. We don't repeat exams at all. That's why I'm saying any problems, any concerns, something's going on, you can't handle it, stop. Let me know. We can get your exam restarted at another time. Okay. It's better to tell me before, hey, I can't take it today. This is going on, and reschedule it than not, taking the exam and, gee, I had a migraine headache. Oh, I was having a heart attack. I've heard all different things. Don't do that. If you can't take it, don't take it, because you cannot repeat it for any reason. And I've already said all that. Your quizzes are in Canvas. They are not in ExamSoft. It will have an access code so that you will all start on time. How many times do you want me to tell you about technical support? I think it's an important concept here, huh? Anything, let me know. And then you have a HESI. It's week 11, and it is 20% of your grade. I do a Saturday before the HESI. I do what I call a HESI Q&A. And what I actually do is I take previous HESIs and look at the concepts from the blueprint. They send us, it was on GI, on intussusception. That's all I know. And I've got to figure out what that could be in a question. And what I've done is I think I've figured out most of it. And I've also got to do last terms. I've got to infuse that into the Q&A. But it's very current, and it really helps you to think, because your next term, most of you, is going to be going into capstone. You all have to know how to think. Information, anybody can regurgitate information. It's how to use it, how to apply that information. If I'm short of breath, what do I do? What am I looking at? What do I need to see? And how do I know it worked? All of those things is things I'm going to try during this term to help you think that way. That's what I'm going to do. I also have a great HESI handout for you. So I've got everything you need for the HESI. Also know that your NCLEX RN book on pediatrics is actually very good, and the HESI hints there are actually excellent. After the HESI, and I'll be putting all of this time in the announcements for you, make sure that you do your remediation. It's always due by the Monday after the HESI, week 12, Monday, it is due. So make sure it's in. And of course, I'll be sending you reminders if it's not, because I'm having the heart attack for you if you're not having one already, getting that remediation in. We know IDs will be there. Again, any problems, let me know. And then your homework. I write things down. I know you guys don't do that today. You put reminders and pings on your computer, etc. Whatever way you know how to do your assignments, keep yourself organized. Most of you are in 3 courses this term. It's a lot. Okay, you've got to be organized. Late work, unless I know about it, it's going to be minus 10%. If I know about it, again, I will give you your full credit, but tell me before it's due. Your NCLEX questions. Remember that first week, remember it is 2 parts. On NCLEX questions, your first week, it talks about different growth and developments. It is not just pediatrics. Be careful on that first NCLEX set of questions. It's going to tell you not to check pediatrics, it's growth and development, which is above, and then click infants, toddlers, preschool, school age, adolescents, okay? It's different. Now, if you send me in the wrong one, I'll give you a 0, but I'll give you another week to get me the right one in. If I give you a 0 for anything, look at the comments inside the assignment. It's telling you why I did that. I don't like to give zeros, but I'm telling you, hey, alert, please give me what I need, okay? Make sure when you send in the NCLEX assignments, you don't send me one of those green box looking things there. I need that whole list out, that 3, 4, 10 pages, whatever it is. I need to look at what you did, what subject you did, what areas you covered, okay? And once you submit your NCLEX questions, that's your score. You cannot resubmit them. I've had students at the end say, hey, can I resubmit that NCLEX question to get more points? I'm sorry. Once it's submitted, no more. So you can do them as many times as you want at home to get the biggest grade you can, but once it's in, it's in. And we already got all those. In the end, on week 8 and week 10, you have the HESI RN practice and assignment exams. Now, these must be done through the course modules. And sometimes there's some crazy things with it, with Evolve. If that happens, just know that you contact me and we'll talk to Dr. Brown and we'll figure it out. Sometimes there's a glitch. That's all this slide is saying about. But it's done through the course module. It's right before the HESI, so it is a great thing. Usually, the grades transfer from the NCLEX, goes right from the HESI practice exam right into the grade book. HESI, the NCLEX, I've got to put in, but this RN practice and assignment exam, it should automatically go over. If it doesn't, and you did it, let me know. I know where to go looking for your grade, and I'll go get it for you. Those sim charts, case studies, Julie has said she's going to send me that recording. Absolutely. You're all going to get it. In fact, I'm going to send it to all my PACE people because I think having that as an extra thing to help is a good thing. How to go through them and how to work them. Because I know last term is the first time that we did them. And students really had a hard time with them. So I'll be sending that recording as soon as I get it for all of you. The papers and the discussion posts. Know that your discussion posts follow what the discussion's saying, follow the peers. Know that with the pediatric assessment, there is a rubric there for you to follow to go down, and I'll be grading by those things. Know that when you're doing that paper, that you don't copy and paste, that you could go to the sites, you can look at this stuff, but use your own words, okay? Make your own words and we'll be okay. Making sure that the information is not too old, and making sure that you have put those resources down that you can cite them properly. So in the end, these are questions for thought that Dr. Brown has written up just for you to understand things that she's looking at. And I'll give you the first one and the last one only. It says, are you prepared to sit for the specialty exam? If you've gone to my course and you've taken the exams and you've studied right and you've looked at those cahoots and you've understand those concepts, you are ready for that specialty exam. It's the same thing as what's the nurse's accountability when on or off duty. I mean, we're nurses, nursing students, future nurses, we're always accountable for ourselves and for our actions. All right, so that was just, the warm up into, hello, this is pediatric nursing, this is online. Nancy and Yvonne, can you come on camera for me, please? Nancy, could you come on camera for me, please?
I think she said she was going to the restroom in the comments.
Okie dokie. Thank you very much. I appreciate that. All right, so now let's go ahead. We're going to do our first week PowerPoint here. Anytime, if you're looking at this and you have any questions, please stop me. I don't get upset. I don't get frazzled, and I'll try to answer it as best as I can, okay?
Professor Bogart, you said that we could like make up the class as long as we attend one this week. Would I be able to come to one of yours later this week? My car is finished. We've been trying to get home for the last 2 days.
Julie, whose class are you in?
Um, I don't know how to say his name. It's Doux.
Okay, so you are in the right class for today. You have taken pediatrics this week. This is your class.
Okay, but the guy just told me that my car is done, so I could come and get it.
Okay, so if you miss class, then you're missing attendance then, Julie.
Okay.
Okay, so
That's
stay
okay.
on as long as you can.
All right.
Okay, my dear.
All right.
Okay, so here we are. Pediatric nursing, chapter 26. You've got blank PowerPoints. I'm going to be sending you this all the time. I tend to take PowerPoints and I put pictures on them. And I change words and I add things according to quizzes, exams, HESI. And I think they tend to describe things better when you have a picture about it. Now, healthy people 2030. When I first started back into nursing school, it was nursing 2010. And I was like, healthy people, what is this all about? And then what I found is this is a government initiative on certain things in health and healthcare that they are focusing to improve. Whether it's dental care, whether it's nutrition, whether it's reading. I mean, you hear all the president's wives with their big focus. One was on reading, one's on health, one's on exercise. These are all the things that we see in it. Now, why am I mentioning this here? Well, as you go further on in your careers, in nursing and wanting to go on in your education, your bachelor degree is going to be all papers. It's going to be PowerPoints and brochures. And where are you going to find all the information to write about? right here, healthy people. Pick one. Talk about nutrition in children. You can write on forever and ever. Mental health in children, on and on. Healthy sexual development. Hey, we're talking kids. How are you going to develop their sexuality? I'm telling you, it's a great place to go. And I'm just throwing it out there for you. So, some of the healthcare problems for children that we'll discuss, obesity. Today fast food is out there because parents don't both have to work, and it's easier to pick up fast food than it is to cook nutritious meals. Plus, it's expensive to cook nutritious meals, getting fruits and vegetables and all those sort of things. It's pretty difficult. So, because of the children getting obesity and they're being obese younger, type 2 diabetes is now higher than ever. Another thing, childhood injuries. Children tend to not think before they do things. So, childhood injuries is a major cause of any sort of injuries for children. Violence, gang violence, any of them. How about vaping epidemic? That became a big crave, still is a big crave. Let's go, vape whatever we're vaping today. And then you think mental health problems in children. I've seen 6-year-olds having bad problems with paranoia and delusions. And it's something you don't forget. My heart really hurt for him because he didn't know how to control his brain. So mental health problems are big in children. So it's another place for you all to work if that's something you like. Infant mortality. Know that the first 28 days of life, you are known as a neonate. At 1 month old, you're known as an infant up to 1 year old. Okay. So, neonates, less than 28 days of life is like where we have the biggest type of infant mortality that goes on there. You remember, the kids are born, they're usually premature, they get bleeds in their brain, they have feeding problems, their intestines get problems. And because of that, a lot of infants die. Now, the one thing I want to tell you, because I worked newborn ICU since the 1980s, the changes that have been made are amazing. The changes that have improved healthcare and survival and quality survival has changed drastically by the ways and methods that we've researched and implemented into nursing care. Nursing care, okay? The way that we touch and handle our infants. How about a 1 pound baby in the palm of your hand? How do you change that diaper? How do you listen? Where do you listen? How do you suction them? Et cetera, et cetera. All of these things have been looked at very closely to decrease infant mortality. And then the other thing I'll mention here is the United States is not doing that good as compared to other countries. I think Scandinavia, I think is one of your biggest ones over that way. Norway, Sweden, I think those have better outcomes, decreased infant mortality. So death rates for children greater than 1 is less than for infants. Remember that first year of life, they're going to get whatever disease it's going to happen, and they're going to be stronger and healthier. They've gotten all of the infections, they're building up their own antibodies. And then by the time ages 5 to 14, now they're learning, they understand, they're following directions, they've been sick, they've built up immunities, they're not going to be ill and die from these sort of things. But then you go to adolescence. When they become adolescents now, they think they're adults, right? These are not the little adults anymore. These are now, they want to be big. So now they're picking up guns and touching them. Their injuries, they don't warm up for sports. They want to hurry up and go, or they're out doing things they shouldn't do, jumping from a tree to the roof of a house to get out of the house and all that stuff, right? And then adolescence, as we start to learn about it, it's a time where adolescents worry about themselves, their body image and their identities, and what am I going to be when I grow up? And all of that's very depressing, and it can lead to suicide. So, as I said, child morbidity happens for certain reasons, and this is, after the infants we're talking about, when you have homeless, poverty, low birth weights, chronic illnesses, those are always going to be high, with problems that can occur because of those things. Also, those foreign born, we don't know all of the sometimes ins and outs of that child and what their medical background and stuff is. And then you're seeing children in daycare. Why is that an increase in childhood morbidity? Well, I'm going to say it like I say every term. What do kids do in daycare all day long? They play. They play with toys. What do they do with the toys? They put it in their mouths and then they give it to the next kid to put it in their mouth. So they swap spit all day long, swapping germs, and those germs could be bad ones, which could cause a childhood morbidity in because of child daycare centers. Now, it's good the kids get sick. We want them to get sick. We want them to get the viruses, build up the antibodies and antigens against it. So when they go to school, yes, but know that there's always a danger in that. So the art of pediatric nursing, family-centered care, right? Is pediatric nursing just a child? No. And one of the reasons why many children don't get into pediatric nursing is because of the parents or the caregivers. They don't want to deal with these really anxious parents and caregivers because their child is ill. And I understand that. Actually, I was that nurse that the most difficult parents were assigned to all the time because I had a little bit of a patience with them. And I learned that they weren't aggressive, angry parents. They just wanted to know about their child to take care of them. And when you treated them to teach them, that's all they wanted from you. And they became actually very good friends long term, some of them with me. Know that the family is the constant in a child's life. That's all they know. Think about it. Where else do they go? Sometimes they might go to their aunt's house or uncle's house or grandma's house. But besides that, it's family. It's all family. That's all they know. Family is a constant. The other thing that we promote in pediatric nursing is something called atraumatic care. Think about going to an emergency room yourself. And you're going to need an IV and blood drawn and a urine, and you're going to need all that stuff. Well, number one, the kid doesn't know what's all going to happen. Nobody told him yet. He's never done that before, so he's nervous. Then they're going to take this needle and stick it in your arm. They didn't give you anything numbing, did they? And it hurts. Those big gauge IV needles they use in the ER hurt. And on an adult, it hurts. Don't you think it hurts a child too to put an IV in? So we're doing we're doing so many things to decrease the type of pain that we give our kids. So we're putting numbing creams down to start IVs, numbing for spinal taps. We put on music. We do distraction. We give them an iPad, blow bubbles, turn on the TV. I would dance and go crazy and act like a crazy person. Everything, all of it works, okay? Atraumatic care. That means we're going to give them the care that they need, and we're not going to give them as much stress and pain as they used to get. I mean, years ago, we didn't numb stuff. We didn't do any of that. I mean, I actually myself developed a program here in Miami called Huggies. And it's an acronym, H period, U period, G period, la, la, la. Help us give great injections efficiently and safely. And what I said, it was for my doctoral dissertation, for my PhD, and it said that children that were held before, during, and after an immunization, a shot, IV, a needle of some sort, had less pain, stress, and anxiety because they were held by a parent or a caregiver. And I proved it through research over and over and over again. So atraumatic care is here, and we're going to go minimize physical, psychological stress and do no harm. So you can see by just the way I'm talking that, pediatric nursing is building that therapeutic relationship. Number one, you've got to build a relationship with a 2-year-old kid. Oh my, and do it this quick. And you've got a therapeutic relationship, those family members, the parents, and it could be a big brother or sister, all of them. So again, knowing how to do that and understanding that they're not here because they want to be. They don't want their kid in an ER, a doctor's office, or a hospital. It's because they have to be. So again, teaching them, being the advocate for that family, teaching them how to prevent diseases and to teach them, everything you can about health and keeping them healthy and that injury prevention. Okay. Nursing, we do a lot. We're also their therapist on the side. So support, counseling, we coordinate, we collaborate, we make sure kids going home needs all of these things to go home with. Did we get the social worker in? Did we get the person to get the equipment home? Was the medications ordered? Do they have the syringes? This is all the coordination, collaboration, nursing, make sure. Now, do we do it ourselves? No, but we have the resources to make sure it's getting done, okay? So, leading cause of death among African American boys ages 15 to 19. What do you think could be?
Gun violence.
It is gun violence, absolutely gun violence. Now, the other ones could be, but gun violence is one. I think all of a sudden they feel like they're old enough to pick up a gun and use it, and they don't realize they didn't know anything they didn't know when they were 6 years old. Nobody's taught them. Okay, so now chapter 27, family, social, cultural, religious influences. So you have a child who knew nothing at birth. They didn't know how to suck, swallow, and breathe. Everything they've learned from their caregivers and people who have been around them. So family, social, cultural, religious comes from the family and the people that have surrounded them, right? So what is a family? That's a big question. It's whatever they say it is. Now, I know that many, many years ago, when my grandson Christian was born, my daughter lived with me. It was my daughter, my grandson, me, and my husband. And that was our family. Fortunately, when the baby was about 2, she met an awesome man, and they're not here anymore. So my family's just me and we'll call him Pop Pop now, me and my husband. And now she's her own family. Now, it doesn't matter to women, to men, grandma, grandpa, adopted. A family is whoever, whatever they consider it to be. Okay. So it's a broad definition. These are my family. Could be the next door neighbor who you've been there for life. They're family, aren't they? So those are all the names. You don't need the names, but there they are. So family strength. Well, we know that families are what holds a child together and it teaches them. So with a family's support, you can help take care of your child a lot better and give them what they need. Knowing that, everybody has something they're good at and some things that they're weak at. But I think families always try to give that child the best of what they got. There's all sorts of parenting style. You got the ones that let them do whatever. You've got some parents who, lets them there's certain things they can get away with and certain things that they cannot, and that's setting that limits and that discipline, and then having discipline that go with it. So that there's all types. There's grandma parenting and then there's mama parenting, right? Grandmas get to spoil the children a little bit, but mom and dad have that routine and structure down to make sure that they are disciplined, so then they go off into the world, they know how to handle themselves. We know that parenting all different kids is all different. It doesn't matter. Every child needs that special understanding. There's some more special ones. So children, family. Understanding who a child is actually can help you figure out how to take care of them. You know, other things that do involve and help children evolve, of course, is their schools, their peers, their community. It could be like a church community. And as they get older, are they into that social media type things also? So a frequent health problem of migrant children and adolescents in the United States could be, what do you think? Migrants, what could they possibly bring to us?
Tuberculosis.
TB.
It's TB. And we don't think about that. Think about me. I live in South Florida. I have a huge area of farming that's here all the time. You know, it's 12 months a year. And we do get a lot of migrant workers here. I've got to be, as a nurse, I've got to be concerned if they're coming in with symptoms of TB. I put a mask on them and me, right? So again, that's why I'm mentioning these sort of things. It does affect me, and I'm not a migrant, all right, but I work with them. So genetic influences. So as I said, children start at age 0. They can't even breathe. You smack them on their butt, per se, and they breathe. And then all of a sudden you put something in their mouth and then they suck. And then they suck and they breathe. And then you put some milk in their mouth, whether breast or a bottle, and they suck, they swallow, they breathe. How do they do it? It's amazing because I think it's interrelated, simultaneous, ongoing. And unless you have this eye that can watch, it happens so quick you don't know what happened. They cannot breathe at birth. They are walking and talking in 12 months. What have they done in between? Interrelated, simultaneous, ongoing. They turn over, they're on their knees, they're up on their legs, and they're walking. It's amazing. So, types of growth. There is something called directional growth, which is we grow up, right? We go tall. Sequential. You lift your head first. That's the first thing a child learns to do. They lift their head. And then they learn to turn over. Then they get on their knees. And then they're going to crawl. And then they get up on their feet and they creep around the coffee table and the little sofa. And then they start walking. That's sequential. Developmental pace is hitting the milestones. Milestones are, when did they turn from their abdomen to their back? When did they get up on their knees? When did they start standing up? Those things. And sensitive periods are those areas in between where they're not doing much of anything and they're sitting and learning those stages, okay? So, infants, different than other children. Their metabolism, heart rate 140 to 160. Temperature, they don't hold their own temperature at birth. These children need extra clothes. Why do you think we immediately wipe all the wetness off, put a hat on them, and put them underneath a warmer at birth? They don't hold their own temperature. It just escapes quickly. It takes a while for an infant, a neonate, to become an infant who can hold their temperature well. We know that rest and sleep, babies eat, sleep, eat, sleep, eat, sleep, eat, sleep, right? And as I said before, and you're going to hear me say it again, nutrition, 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 the single most important influence on growth. We actually weigh children every time, don't we? It's one thing we do. Height and weight, every kid from birth till they're out of the pediatrician's office. You don't do that in adult world. I don't remember the last weight I did in an adult office. I've been telling them a lie for many, many years, okay? Yes, yeah, I don't weigh that much. You know, it's a little bit less than that. But children, we do. Why? Well, especially the younger ones. If we don't see their weight doubled by 6 months of age, we have to look at, because it's a developmental stage there. If they don't, they're 4 pounds. Why? They're not getting nutrition. So if they're 6 months, they should be rolling completely over. This kid can't even hold his head up. Cognitively, they'll be delayed. And physically, they're not going to be where they need to be. So without nutrition, they're not growing their brains or their bodies, okay? Children all act differently. Now, I just went on vacation with an 8-month-old baby. Well, we called him the miracle baby. That kid would go to sleep on a chair in the middle of a restaurant, at a show. I mean, this kid never cried. He got either changed, he got fed, or he got put down, and he does not like to be rocked to sleep either. Oh, okay, fine, here, put him down, put a blanket on his head. He goes to sleep. That is the easiest child I've ever met in my life. Now, at work, I always got the most difficult child. These are children for whatever reason, they can't calm down. They need extra loving or rocking or cuddling or swaddling or a pacifier. They need something to get them to calm down. Another one of those children are the ones that are just, I don't know who you are. Oh, you're not touching me. That slow to warm up child. And we know kids' temperament are all different and all different kids. Now, I'm not going to go over completely the theorists today, but I want you to know that you're going to be hit hard on your first exam on theorists. So as I go through them, try to pick up a little every time. Probably about 4 times you're going to hear me go through them in the next couple weeks. So Freud. What you need to remember is anything about sex. Psychosexual, what their mind thinks about sex, basically. Infants love their mouth, pacifier, everything in their mouth, explore the world mouth. Anal, potty training. Phallic, they're learning boys and girls are different. Boys like mommies and girls like daddies. That's that stage. Latency, I'll go into that another time because it doesn't make sense, but it will once I tell you. It's basically just same-sex peers. And then adolescence. What do they think about? They're hormonal, right? It's all about their genitals. So that is Freud. Now, Erickson talks about the mind and social, the people around them. So Erickson thinks about how this child thinks about people around them. So an infant up to 1 year old, they can either trust you or mistrust. They trust you because you change them, you burp them, you feed them, you lay them down when they're tired. All their needs are met and they're happy. The mistrust, that is a child who's not picked up, not just once, all the time. They're not picked up. They cry, nobody comes. They're not fed. This could be in an abusive environment, could be drug, alcohol abuse. Something's going on that's causing that mistrust. Autonomy is your toddler. All I'll say about autonomy is automatically me, mine. Toddlers, everything is mine. I do, I wanna, it's mine. Initiative, preschoolers, they like to do things and to help. I'm not going to talk about school age because I have to describe an industry to you. It's just basically what they do well. It's their factory. My industry, what do I do good? I'm good at spelling. I'm a fast runner. I'm good at coloring in the lines, whatever it is. And then, as I mentioned earlier, identity. This is your adolescence. All of a sudden, they're growing up. They're going through puberty. They are getting excited by males or females or whatever they're excited in. And they're like, ooh, but I got to grow up and be something. What am I going to be? So it's a really hard time. Then we have Piaget. This is cognitive. This is about thinking. So the first thing that they learned was what? They put something in their mouth and they could suck on it. Oh, I'm going to do that again. Okay. Then they take, and let's do another thing to you. They take a rattle and they put it in the baby's hand. And by a reflex, they don't grab it. By reflex, they grab it. And then all of a sudden that rattle moves and it makes a noise. And that infant goes, ooh, I like that noise, right? So what they do is they take the next time they get that rattle, they take it and they shake it because they know it's going to happen again. And then all of a sudden that rattle falls in that baby's mouth. And oh, they like everything in their mouth. They explore the world in their mouth. And I'm going to eat that rattle now. That's how cognitive is. And as we get older, it goes from doing things to understanding things, and then figuring things out in the end. So I'll go over that more as we go further. Remember, it's about thinking. So language development. We know that babies are born, and what can they do? They can cry, and eventually they coo a little bit, about 2 months. But initially, it's just mostly crying a little bit. So they can tell you what they need and they want, right? Another theorist that we'll talk about is Kohlberg. Now, Kohlberg talks about being your morality, doing right or wrong, okay? Now, infants and toddlers do not know right or wrong. They don't know that, okay? As preschoolers, they're starting to understand not right or wrong, they're understanding reward and punishment. And as we get older, that morality becomes broader and broader. As school age, people want to please and do good, and that's Kohlberg. Again, it's right and wrong, a consequence for each, and it starts with those preschoolers. Okay, how to play. We describe plays by what children do, and actually their age actually describes their play too. It could be around people. That sense pleasure is like taking sand or mashed potatoes in their hands and swishing it around. That's a sense pleasure. Like clay, painting with their fingers. They love that sort of stuff. Skill play could be like Legos, building Legos. Unoccupied play behavior means by yourself. Dramatic or pretend play, we sometimes use that in a hospital setting. That's figuring out what's gone on that's upset them or made them happy. And we know games. Children love games, and got to make sure that the game's appropriate. So toys and play. I mean, this little kid's had a lot of fun with some purple paint, hasn't he? And I'm sure mom's going to be really upset to put this kid in the tub when she's done, right? But that's all about that sense pleasure, isn't it? It's sensory motor, and you see it's in his hands, and you see it's in his mouth, and that's just part of what they do. And what it does, it shows them little things. It's like, oh, this color, and I can move it from here to here. They think that's a big thing. That's intellectual development. And then as we're playing with these things, it's socialization. It's looking at this kid with all of this colors, go, oh my goodness, what have you done? And seeing that creativity, then being aware that, oh my God, I'm full of this paint, I'm in trouble, right? All of these things actually benefit a child to experiment and to explore. So you need to know the names of play. Onlooker play, that's easy, I'm looking. Watching you play. Solitary play, I'm playing all by myself. Now, parallel play is two kids next to each other, but they're not sharing toys. They're not playing with each other. I'm playing here and they're playing there. That's parallel play. This is toddlers because they don't share, right? Me, mine, automatically me, mine. They don't share, so parallel play. And as we get older and we go into that preschool, we go into an associative play. And now, okay, two or more kids playing with all the toys all together, but they're all playing their own way. They don't have a goal, but they're all playing with all the same stuff. That's associative play. That's preschoolers. As we get up to the young school age children and older school age children, it's called cooperative play. And what that is this is all right. We've got all of these blocks, guys. Let's build a castle. And there's the flag. We'll put it on when we're done. Now, This is two or more children playing together, and there's a goal in the end. Did they build a sandcastle? Did they build, a racetrack? Did they finish building it up? It's doing something. It could be playing checkers, it could be playing a board game. There is a goal in the end. Okay, that's cooperative play. So, toys. Why do we have toys for these kids, especially infants? Do they really know what those toys are? Well, they hear noises, sounds, and see bright colors, right? So, put that toy in front of them and put them on their tummy time, where you need to do, because we need to straighten that flat of their heads out a little bit now. So they're on their tummy and they're using their muscles and they're thinking and they're trying to get there. So they really need that to support and build that muscle strength there. So that's why we do it. It's for that coordination, it's for that pushing. And then all of a sudden they're rolling over and then rolling the other way. So these are all important things, toys that encourages them to move. Now, doing an assessment on a child. Now, when you are an adult, you do a head to toe, never with a child. If you have a child who's coming in who's a 3-year-old child, let's say they're coming in and this complaint is cough, fever. First of all, I want to listen or look at what the lungs are doing. So it goes to more focused initially. And then whenever you can get the rest of it in, you do. Because children will not sit there like that. A child with disabilities. Now, that top left corner there is a child that appears to me having cerebral palsy, but just by the way her hands and her face appears. Now, they can talk to you, and some of them are nonverbal. If you hear a nonverbal crying, they're telling you something's happening. You have to go look. You touch and feel, and they'll groan if it gets to a place where it hurts. But all ages children, we can assess from infants all the way up and the nonverbals in between. Now, there's a bunch of genetic things that can happen at birth, during pregnancy, and they could be born with things like club foot. They could have cleft lips. They could have syndromes. You've all heard of, Down syndrome, but I can't even tell you how many hundreds and hundreds of syndromes there are. I worked in an emergency room the last 10 years of my career, and a child would come in with a new syndrome. I'm like, ooh, which one's that? And I'd go and I'd look it up. Prader-Willi and Turner and DeGeorge, and I could go on and on and on. And these are all genetic things. And remember, with genetic disorders, and if parents know that, one of the things is the mother's going to be asking us, of course, because we're pediatric nurses and know everything. It's like, can I have another child? If I have a child with Downs, if I have a child with Prader-Willi, if I have a child with something. And, as nurses, you need an answer. And the response would be well, I think that a genetic consult would help you make the best decision. Isn't that the way to go? So again, the role of the nurse is just to get them directed, supported, and put in the right way so that they can get all the information they need to make good choices and have what they need there for these kids. So communicating. I can talk to a 1-year-old really easy, can't I? Well, this is the first slide I put in here. It's all about HIPAA. I'm guaranteeing you your NCLEX is going to have a question on HIPAA. And I know it's going to be one probably regarding a child. There are, remember, an 18-year-old child who's cognitively aware, alert, normal, quote, child, can sign himself into an emergency room. Remember, you can't tell the parents what's going on with that child unless the child gives you permission. That's the one thing that I had to be worried about as an emergency room nurse, because you get 18-year-olds in, and that child doesn't want the parent to know what's going on. So we're going to go into more about communicating with adolescents and younger kids, etc. But know that HIP is very, very important. Always when you get out of rooms, I mean, every single room today has computers in it, or you have that mobile one with you. Make sure that you protect that. So talking with families. So yeah, we have children, right? But we know that our information about that child is going to be coming from the parents, the caregiver, or whoever's with that child, right? And you want that child to tell that parent to tell you what's going on. Now, the problem with asking a parent globally, so what's going on with your child, they're going to be starting many of them. Well, at birth, now the kid's 8 years old, well, at birth, the kid weighed 6 pounds and he had a little trouble breathing. And she's going to try to go on through 8 years of his life. And, we have that initial information. Today, we're so lucky. Medical records just go on, they just get bigger and bigger. And we have from birth information now. I think that's great. So we can see that easier, right? But this parent, what you need to do is, so why are you here now? This visit, what's happening to your child? Why are you upset? Why are you concerned? That's directing the focus. Another thing I had to be aware of, and I'm from an area which didn't have many type of cultures in it at all. And I had to move to Miami, and now my children have a Cuban father. I'm married to a Jamaican. I have friends that are Dominican. I have friends that are all different cultures and races. And I love learning about all of them. So I needed to know that as a new nurse down here, that cultural awareness was very important. There's some cultures you can't look at them in their eyes. You can't look at the mother. It's the father that gets all the information. You can't direct information there. Sometimes light switches can't be turned off and on. Shoelaces can't be tied. All of these things are things that's happened to me that all had to do with culture and beliefs from these culture and religious sort of things. So again, just being aware, some things that you've never heard of, and just if that's what they believe in, that's fine. All you have to know is what you believe in. You don't have to understand. You don't have to believe in what they want, but as long as it doesn't cause harm to the child, yes, whatever they need to do, you do. Okay. One of the things that we tend to do is try to talk over people giving us information. I think using that silence is key. Give them that chance to get it out, and that parents feels good that they were able to get it out. Another thing I've learned, especially in pediatrics, is being empathetic. Can you imagine bringing in a 4-month-old baby who's been sick for a week? They've been at the doctor's twice. She has 3 other kids at home, and she works full time. Can I be empathetic to that mother who finally got to that baby to the ER this Saturday morning, her day off? And I'm going to say, oh my goodness, you must be exhausted. You have done a great job. Let us take care of you. Let's see what we can do. Would you like to get a cup of coffee? Let me watch your child. Go ahead, go get a cup of coffee, or I'll bring her one myself. Something like that is $1,000,000 to that young parent of a 4-month-old who's been sick for a week. And using things like that really, really help. That avoids all the blocks to communication, right? Another thing is when I moved down here, only spoke English. I'm actually quite good at Spanish today because of where I live, because of the ex-husband. But if you don't know the words, do not go to that older child of the family because they're going to interpret your words and make it their way they think you are saying. So that little blue phone today, or if there's an interpreter in the hospital, absolutely, that is what you will use. How do you talk to kids that are young? Well, infancy is that cuckoo gaga and that little touch and that little giggle things. And we know how to do that. As we get into that toddler, the one thing you need to know about communicating with young children is you need to get down. You can't stand above them. Get on their level. That's number one. Number two, you need to talk them in a manner that they'll understand on their developmental level. Do they understand? I think using play on that young age is perfect. I said, is this my nose, or no, is this my ear? Is this my nose? And they'll giggle and they'll show me. I'm telling you, little things like that help. School age children, again, they want to know what's going on. Be honest. Knowing if it's going to hurt, and you're going to hear this many times this course, if something's going to hurt, be honest. It's going to hurt a little, but I'll do everything to make it as little as possible. Okay? And we know communicating with an adolescent can be very difficult. Know that sometimes we can kick the parents out of the room and talk to them, and sometimes they'll give us information that can help us with their medical care. So now you've got a parent in the room with you, or maybe some other people with them. The first thing is, I've actually walked in, and I'll always remember this whenever I see this slide. I walked into this room with one child and it had 9 adults in it. And I looked up and I said, okay, I need one person to tell me, why is Javier here, or whatever his name was. And then it was actually not the mother, it was the aunt who had that child all that weekend. So I said, okay, tell me whatever, and other information I'll ask you, Mom. Again, you don't want 9 people to, well, these did this and I did this and I saw this, and nothing's going to make sense at all. Another thing, like I said earlier, why are they here today? That chief complaint. And then cough, fever, what's the first thing I'm going to do? I'm going to use these eyes and I'm going to look, is that child breathing, and how are they breathing? If you're telling me they're in abdominal pain, are they bent over? If they say something's broken, does it look swollen? Does it have neurovascular signs? Analyzing that. So you know now what nursing care has to get done. History is going to include a lot of things. Initially, knowing allergies, medications, and really important is immunizations. If you have a child who's not been immunized, and there are some parents due to religious or whatever reasons who do not immunize their child, they come in with symptoms that could mimic a very contagious disease like pertussis. I would want to know if they have their immunizations, because I'm going to put a mask on me and that child into an airflow room to protect the rest of my children that are in around my area. Okay, so immunizations is very, very important, and allergies and medications. As we admit a child being now admitted into a hospital, we want to know their dietary. What do they eat? What do they don't eat? What do they don't like? What are they intolerant to? Anything that their past history, of course. And then understanding the growth development. Are they at that 2-year-old stage like the kids too? Is he 2-year-old in that growth, or is he behind? Is he ahead? And then I want to know habits. Sometimes if I knew they have that special little blankie they need when they're upset, mommy had to run to the cafeteria to get something to eat. The child's in the room, the kid starts crying. What am I going to do? I'm going to get that blankie and put it up to him and give it to him. It fell on the floor, right? Now I've solved a problem just by knowing habits. With older kids, it's that sexual history. Again, you can have parents leave the room and get that information. You don't have to tell the parents what that adolescent told you, unless it's something that will hurt them or other people, okay? Another important thing that I found out is that I want to know the family structure, like who's in charge, who has the final say. Is it mommy? Is it daddy? Or is it grandma? There are some grandmas, abuelas in Miami that can be pretty strong. So who's the one who's going to help me make decisions here? One of the things I do ask my children, trying to evaluate myself, what developmental stage they are and how they're going to respond to me, is how are they in school? I'll say, so how are you in school? What's your favorite subject? Or who's your teacher? And then if they get, they get B's, I'm going to be, oh, that's good job. So I'm hearing there's interest, okay? Um, I'm also going to be watching things like how is the mom and the or dad and this child acting? I had an ER that had separate rooms for every child that was placed in them, okay? And child be put in with the parent, guardian, whoever, and the door would be closed. I'm going to walk in the door to do my initial assessment, find out what's going on, etc. And if I see a child on top of the stretcher with all the earpieces thrown all over the place, or the otoscope on the floor, or the drawer with all the alcohol wipes all over, and the parents sitting there on the phone watching TV, I know that I'm going to have a little bit more trouble working with this child because even the mother can't hold this child and keep them calm. So again, I'm going to be looking for those things. What if I have to give this child a medication? Are they going to take it? That's going to be something else too. As they're admitted, I want to know their dietary intake. Some cultures are just vegetarian. Some cultures don't eat meat, but they eat only chicken. They don't eat pork. They don't eat cow. They don't eat whatever. Understanding that is something you should do. Checking their tray before it walks in. If they're vegetarian and the breakfast tray comes up and there's bacon on that tray, I would not send that into that room. It just gives respect that you listened, okay? Another thing is, if they are that vegetarian, is their hemoglobin hematocrit okay, or are they iron deficient? Because iron deficiency anemia is very common in vegetarians. So again, being aware of who your child is because of their culture, what they're eating can affect parts of the body. Understanding that can help us take care of that child better. So that sequence of examining, that head to toe is for adults only, like I said, okay? And as I said, you're only going to do first focused, and then you'll get everything else that you can get as you want or as you can. Another thing is getting that child ready for an examination, and you have to look at their abdomens and listen to their heart, etc. Especially in some cultures, always just expose what you need to expose. Even children get really timid about their bodies, okay? I've seen that like in preschoolers and up, like making sure that you give them all of that type of uh, privacy that you can possibly do for them. Also, what you're going to do, tell them first. Sometimes younger kids, I'm going to have them take a blood pressure on me first, or take a temperature on me first, or maybe I'll listen to their toe and they can listen to my heart. I mean, these are things you do to play, to distract, to get what you need getting done. Getting kids ready for these painful procedures, that IV going in, as I said, having parents there does help, whether it's on their lap, standing next to them, using distraction. I've used iPads, I've used bubbles, I've used all different little things. I used to always carry stickers, boys and girls stickers, all ages in my pocket. And these kids would do anything for a sticker, and it just helped give them that quote reward for listening, right? you know, Always when you're working with a child, always do it age appropriate. They're on their own developmental level. I mean, you're going to talk to a 12-year-old different than a 3-year-old. But the same thing is getting them positioned and getting them prepared for exactly what you're going to do. So, which approach would be best to use to ensure a positive response from a toddler?
A
High level,
Right. You don't want to be above them. I'm not a little woman, and I could be threatening. I used to sit even below them and sit there and put my hand like this on the stretcher or the bed next to them, say, "So I'm Betty. Who are you?" And just make it comfortable. And now I'm not threatening at all, am I? So those are things we do. So the assessment, we do a lot of different things. Height, the weight, important. Head circumference. Why would we do head circumference on infants? It's because they're growing and they could get hydrocephalus, right? So we want to make sure the head is grown the way it should. In the newborn ICU, you do it every assessment, every beginning of shift, you do it. We will listen to pulses apical till they're 5 years old. We need to know what is a normal apical pulse for a 1-year-old, a neonate, a 5-year-old. The number goes down as they get older. We know adults is 60 to 100, right? So everything else has to be above that. Blood pressures, we can take a blood pressure on a 1-pound neonate, preemie, we can. And I'm going to show you some of those. And then sometimes we even do that orthostatic type of blood pressures on them. Know that kids, one thing that you can tell is what we call a general appearance. You heard me say the first thing I'm going to do is look. Are they breathing easy or are they gripping in pain in their abdomen? I'm going to look. That's a general appearance. Children look well or look sick. There's no in between with them. And a kid looking sick is not going to be a fake. They're always really sick. So if a kid doesn't look well, take it to heed. Something's going on. I mean, I can see that bottom picture that is retracting and there's some sort of rash going on there. That picture up top, the kid's smiling. So nothing bad going on there. Lymph nodes. Are lymph nodes there on children? No, unless they're ill. Lymph nodes make stuff to fight infections, right? So if there's no infection anywhere, there should not be any lymph nodes that you can feel at all, okay? So checking everything, do they have ears? I mean, sometimes you have pieces of ears missing. Checking their chest, is it moving? Their heart, their lungs, looking at their abdomen, is it rounded? Is it distended? Is it loopy? All of these things. And then I've actually seen ambiguous genitalia. I've seen actually fused vaginal lips there where we had to put actually just a hormone cream on it. These parents had to get this child. So looking at everything, know what's going on. There's something that an anus, why would we be looking at be on it? They're all there, right? Well, sometimes I never saw one in my career, but it's called an imperforated anus. Child born without one. Again, it's an emergency. We've got to get that waste going somewhere. Looking at their backs, their muscles, their joints, their reflexes, and these are where we measure these things. Now, at birth in OB, and OB, you were taught the baby's heads are bigger than their chests, right? By the time they're about 1.5, their chest and head should be equal, or their chest should be bigger than their head. Okay, that's a change from the baby. Trying to get a height on a baby, you think it's pretty easy. Now, this looks like about a 2-year-old little girl. And they see that big piece of wood coming down. They think it's going to bop and go right through their head. So do you know what I do? I'll get on the little thing to do my height. I'll put it there and I'll tap it. I go, oh, it's touching. Okay, what's the number? So I get the kid involved and we get my number. I said, okay, your turn. And they go, pat, pat, pat. Oh, it's touching my head. And then, okay, let's see what your number is. And we give it an applause. We got a good number. It sounds bizarre, but these little children, they just want to be a part of it. They don't want to be frightened. They want to know what's going on, and they will cooperate. Blood pressure cuffs, remember it's 40% of the upper arm. We know that, but it could be taken anywhere. Actually, on your younger kids, the preschoolers, the toddlers, I like putting it on number D, the lower leg. And you still get a very, very good blood pressure with that. Now, cardiac children, you're going to learn we do 4 extremity blood pressure. So we do routinely lower extremity blood pressures. And then the last thing is pain. Now, pain is high hit questions on exams, quizzes, HESI, and CLEX. They love talking about pain and they love talking about it with children and measuring this sort of thing, okay? So, children, they're always going to suffer. You know why? They don't want to admit they're having pain. Why? They don't want the needle, the shot, or they don't want the medicine. They're scared of it. So we need to change that around. So they're in pain. That's one of the reasons. Another thing they're in pain is because nurses are like, oh, that's too much medicine. I don't want to give them that much. So let me just give them a half dose. So not enough medicine. Or, oh, they had morphine. I can't give them anything else. They look like they're in pain, but it's not due for 2 hours. But I have a ibuprofen order. I could have given that, couldn't have I? Yes, you could have. So not giving things the way that they should, waiting too long. And then the other thing is not going back and evaluating when you gave that medicine. Did it work? There was a program where I worked called PI, pain intervention, and then you go back and you assess, did it work? So again, pain, very important, making sure not only you give it to them, you identify they have it, you give it to them, and did it work? And remember, it's not just the medicine. It could be a hot pack, a cold pack, could be lifting their head. They had just had abdominal surgery. They're laying flat. Lift the head of their bed, bend their knees up, turn them on their side. All that stuff works. So one of the things, pain levels we use is called FLAC. FLAC is used for children 0 to age 3. At 3, it turns to faces. So 0 to 3, it's FLAC. And what we do is we look at the child. Is their face grimaced? Are their legs movement? Or are they just laying still and can't move? Are they crying? And can you console them? We use this for the little tiny ones that can't express a number or cannot express anything, how they hurt. It's also used for nonverbal children. That picture of that CP child that probably was 15, nonverbal, I'd be using a FLAC scale on her. That would show me her faces. Did she look like she's grimacing? Does she, legs were moving? Was she crying? Was she, all those things? I'd be using a FLAC scale and it works just as well. Now the next scale from FLAC, now there's all these other little scales here. You need to know FLAC, you need to know faces, you need to know numeric. I'm telling you, there's other ones, but those are the 3 ones that are basically used. The faces scale is that picture right there of faces. Wong Baker, it was the people who developed it. And they said that these faces could represent the numeric scale 0 to 10. Sometimes they go 0, 2, 4, 6, 8, 10. Sometimes they do every little number, but whatever works. I've had little 2-year-olds point to like the number 6 severe, and I'm like, oh my God, they must really hurt. And the thing about children in pain, they don't lie. They do not lie, which is the best thing. So this is for 3. You could have an adolescent do this, 3 and up. But they say at age 8, you can do numeric. Okay? Remember, the pain scale has to be appropriate for that child's developmental level, right? So faces, ages 3 up, FLAC, 0 to ages up to 3, and you're nonverbal on that too, okay? And at age 8, we go by the numeric there. Adults have pain that are chronic, reoccurrent, and persistent. Well, So do children. Just think about sickle cell disease. Isn't that something that creates pain every now and then? Our infants uh, don't have sickle cell. Yes, they do. So this can happen. Rheumatoid arthritis, these things, chronic, reoccurrent, persistent. And we know if we don't take care of these kids are going to be very depressed kids because they're always in pain, right? It causes physical, emotional, social problems with school. Complete shutdown if we're not going to take care of this child's pain. Very, very important. I mean, just like adults, we need to take care of them, but kids in pain, especially, I know I've never seen a young kid exaggerate. In fact, they under exaggerate what they're telling me their pain is. Also know that um, there are different sort of chronic pain checklists out there. Not that you need to know it, but there's hospitals all have different things for different types of children and adults. Just find out what your hospital is going to use and use that form. The other thing I want you to know about pain and culture that I found out is many times I would be in the orthopedic room where I was helping children come in and get casts on. They had broken arms, legs, wrists, fingers, whatever it was. And they would come in with their parent. When a child came in, Hispanic, with a father, I would say, "Would you like me to get you something for pain?" And the dad goes, "Oh, no, he don't need anything. He's fine." And I'm like, the kid hurts. I've even had them be such a bad break that the physician wanted to give a little tiny dose of morphine. No, he's not gonna, no, he don't need that. No, 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 he's fine. He's gonna man up. He's good. That's the culture. And you can't go against it. You can try your hardest to protect your child, but I would have 3 ice bags ready for him as soon as that cast was done and put it right on there because I know this kid's going to be hurting. Okay. So, pain management, it's not just the medicine, it's that ice bag, it is that heat pack. And for infants and young children, you know what is the best pain reliever? A pacifier, non-nutritive sucking, it's called. I Part of my research, I researched about children's pain, right? And what I found out is by the study done by a Harvard neurophysiologist or something, research from Harvard came out that researched circumcision in males with morphine and with sugar water, sucrose, on a pacifier. Do you know what they found? No difference. The pacifier worked just as good as the morphine. My grandson had his circumcision done with just the sucrose and the pacifier. He cried when he was placed in the thing that had to hold him down because he didn't want to be held down. But as soon as he came up, had his pacifier, he didn't cry again due to circumcision pain. So it does work. That's what I'm telling you about. Sometimes it's something simple. It also could be swaddling an infant, putting a tight blanket around them. Or what about kangaroo care? You see that mother there? She's in kangaroo care, skin to baby. I've watched kids restless and can't get, comfortable, heart rate's up, blood pressure's up. Mom comes in, puts the baby next to her skin. The baby goes to sleep, the heart rate comes down, the blood pressure comes down, and it's the most wonderful thing to watch. That kid's so happy. Kangaroo care. And as I said, pain management isn't just the big narcotics. It is the acetaminophen. It is the nonsteroidal inflammatories. It's also the older kids can get some of that PCA pump and whatnot, but usually it's that alternating, just maybe that narcotic with those things, adding some cool and heat on them too. This little girl is not upset because that is an EMLA cream put on her arm to numb the area so she can get blood drawn. And she knows it's not going to hurt. We do that for blood. We do that for IVs. We can do that for spinal taps. Anything with a lot of pain, suturing things. These are things that we could put all this numbing stuff on and it could help them. And again, it makes a kid, especially that one who's chronically in a hospital, feel better. Pain comes from everywhere. I can't, I mean, it starts with teething, doesn't it? And that circumcision that goes on, and then all the things and bumps and bruises that they get into. So, which of the following is an important factor for consideration in understanding the pain experienced in children?
D.
Children may not admit to having pain. No, absolutely. So we're going to go to a Kahoot. How does that sound? And the Kahoot that's on your PowerPoint and Professor Scouts, I'll be sending it to you too. Everything, you can get everything that my class gets. All right. And I know he does use my information, so you're going to get that. Where are we? 1 second. I will be sending you also the Kahoots. Don't worry, you get it all. And I'm usually done within an hour after class. Everything should be posted. Just to alleviate any fear, I do not go back and look at the results. I don't look at how many you did right or wrong. This is here for you as an instant test of, do I understand what's going on? So don't be afraid to put your names there or your nickname or whatever you want. It's not, it doesn't hurt you in any way. All right, we're going to get going. There's 31. We're right on time today. 33. The leading cause of death from unintentional injuries in children is.
I'm still trying to log in. I'm sorry.
It's okay. Take your time.
Okay.
That be motor vehicle?
You
I
know,
can't even see what the answers are.
Okay, so if you have your phone, you can push the red, the blue, the yellow, or the green. The answers are on the computer. So you need two devices in order to do this.
Well, I can't see it though. For some reason, it's down. Like I couldn't see them at all.
So, okay, listen,
Let me try to
okay?
fix.
Then just try to listen and you'll have the recording with it. So one thing about children, any age, it's all about motor vehicle fatalities, whether they're in the car seat wrong, infants, toddlers, preschooler, ran over by cars, and I've seen 3 of those happen, or now they're school age adolescents climbing on top of cars, rolling around, or now they're driving. So motor vehicle related fatalities is number 1, okay? Which statement is most descriptive of pediatric family-centered care? Now, when we talk about family-centered care, we know it's like that because the only thing a child knows is his family. So it recognizes the family is the constant in their life. Very good. The major cause of death for children older than 1 year is so if they're older than one, they're toddlers. They're all about me, mine, I do, I want to. They're climbing up couches, falling on their heads, climbing up fronts of dressers, and TVs are falling over. All these things, and I've seen all those, are all unintentional injuries. It happens. It's because kids get hurt. The nurse caring for the child in pain understands that distraction. So again, anything that we do, we talk to a child or we accompany pain management with, all's got to be on the level of that child, developmentally appropriate. You would not give a sticker to an infant. They don't think that's funny. If you rattled a rattle, they go, ooh, and they'd forget about the pain. That's what I'm talking about. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? They're playing together, but there's no organization, there's no goal. That is your preschool children. And it's called associative. When we talk about children that are parallel, they're next to each other. Remember, parallel is two lines next to each other, and they don't touch, they don't play. That's all those kids that want me, mine, toddlers. They don't share me, mine, I do. Parallel, okay? You're going to get a couple more of these. Which statement best describes the process of critical thinking? Yeah, isn't this something that when you were in nursing orientation the first day, they talked about how you had to learn how to critically think? And you think that critical thinking is this big magical thing. Well, you all came here because you knew that you had to look at something and get a Zoom link and to get here. That's all critical thinking. And if you didn't know, you asked somebody to get here. And you know that for dinner tonight, you're either going to do this, or that, and whatever works good for you is what you're going to do. That's your goal. Every day, you're always thinking about a goal. In medicine, it's all about making that patient, that child feel better, right? You want a better outcome, whether less pain, less infection, whatever. So that's what critical thinking is all about. What is probably the single most important influence on growth at all stages of development? Can you hear me saying it out loud? Nutrition, nutrition, nutrition. Good. Which function of play is a major component of play at all ages? What does play do for that child? Right? I mean, why do we have toys? What's that all about? Why do we have to play? I mean, I still play one word game on my phone. It's all about sensoromotor, sense, touch, ori, mouth, motor, movement. It's all talking about things around them and how they all work. sensorimotor activity, and it gives them that intelligence. It gets that cognitive moving, that mind moving. How do you apply nystatin to an infant with thrush? Thrush is that fungus on their tongue that looks white, that if you take a tongue depressor, you can't scrape it off, and it actually hurts. So infants are different than adults. We don't swish and swallow or swish and spit. We have to take a cotton swab and just paint it where that white coat thing is, okay? The difference between adults and children. 3 children playing a board game would be an example of what? 3 kids, 2 or more children playing a board game. Isn't that a goal? Somebody's going to win. These are your school-age children. And that's cooperative play. Very good. The head to tail direction of growth is referred to as, think about another word for head, another word for tail. Isn't a head cephalic? So that's the only word it could be. Cephalocaudal. What that means is they lift their head first. The last thing they do is stand up on their feet, caudal. Head to standing up, okay? What is the single most important factor to consider when communicating with children? And it's that child's developmental level. You're not going to give a adolescent a sticker. They're going to think you're nuts, okay? And you're not going to give it to an infant. But boy, a little preschooler giving a Spider-Man would be awesome. So again, getting on their level so that you know they understand what you're trying to tell them, what you need to do. What 2-year-old child pain assessment tool should the nurse use? 2 years. Which one is it? So up to age 3, it is flack. At age 3, it turns to faces. This is the most common error on exams and quizzes. These, you need to know them. At 6 months, an infant's birth weight should do what? You know, every visit in peds, they do a height and a weight. And that weight in the first year of life is telling us if they're getting enough nutrition. So at 6 months, it should double. By 1 year, it should triple. And this height also, it's telling you, are all the hormones like the thyroid hormone and all of that and nutrition working? I mean, the first 6 months of life, every month they gain 1 inch. That's 6 inches in the first 6 months of life. Plus, they've doubled their birth weight. So these are things, growth, development, that you'll need to know. The first expected fine motor developmental milestone for an infant begins with, remember I told you? Fine motor is F for fingers. What's the first thing I told you they did with that rattle? And as you go to chapter 31 and start reading about infants, you're going to see fine motor skills are with fingers. Starts with initially, and I've seen this a lot, mommy goes over to the infant, puts their hand right by the baby, and they grasp it. And they go, oh my goodness, they've hugged me already, got my finger. I'm not going to tell them it was a reflex. Don't you ever tell a new mother that it was a reflex. Let her think her mother, that little baby has just hugged her little finger, okay? Then it turns into a voluntary palmar grasp. It's the whole palm. As we get older, it starts about 7 months. This little smush up the Cheerios into the face with a crude pincer grasp. And then it goes into this one, like that, little fine, neat pincer. And then the rest of the fingers goes, you can put objects into a container at 11 months, a block of 2, 1 year old. That's fine motor. So reflex, voluntary, crude pincer, neat pincer, putting things in objects and containers, and then block of 2, building a tower. An 8-month-old infant should expect to perform which fine motor skills? What I just said, what do you think? 8 months. So he's not putting objects in a container. That's at 11 months. So we have gone from that grasp to the pincer. So yes, we can grasp it ourselves. And now we're not in that fine pincer yet. We're more of that smushed all of the Cheerios into the face type of pincer type grasp. Not bad though. Good job. The natural physical developmental sequence that most children follow is the first year of life. What do they do? So we know number one is always the head's going to lift. That's the first physical, gross motor type skills. That is the head. We have control of the head. It's by about 2 months old, okay? They start to roll over at 5 months, abdomen to back. 6 months, back to abdomen. Then they get up on their knees. They crawl. About 8 months, about 9 months, they could be up on their feet. They could be cruising and then close to attempting or walking by 12 months. Now, it doesn't mean every child follows all of that exactly, okay? They might skip a step, and that's okay, as long as they're moving forward and everything else. But number one, always gross motor, physical development, head's always first. Which behavior indicates that an infant has developed object permanence? We'll go into more of this next week, but infants are very smart and they understand more than you think they do. I've got an 8-month-old in the house now, and he is showing my daughter every day how smart he is. You can take his favorite toy and you can hide it behind something. Put him on tummy time, and that kid will go right to it. He'll actively search for it. And that starts as an infant. Even though it's hidden, they know it's there somewhere. Bring it to me, okay? As we get older, an infant, we put the toys away at night, right? What do? They come out right to the toy box, get their toy, and continue to play. But even infants, we call that object permanence. They understand it. It's permanently in the brain. They're going to figure it out. They know it's there. Where's my object? In general, an infant should triple their birth weight at what months of age? So we double at 6 months, we triple at 1 year. Do you know when they quadruple? When they're 2.5 years old. Can you see how much they grow that first year of their life? It takes till 2.5 to do what they've done in the first year. Amazing. I think it's amazing. Perform a head to toe assessment on a toddler. Most important to consider before beginning the examination. Any child, any age, always make sure you're on their developmental level. Even though a child is 12, you don't know if they're mentally there, okay? Make sure before talking to a child, you know how to talk to them. It's going to save you time and energy. It's going to stop frustration for the child and yourself. Always on their level, and the first time you'll get what you need done. If you explain it, they understand it. According to Piaget, toddlers are in the blank developmental stage. What did I tell you about what toddlers are all about? They're playing, right? What's play all about? It's all about sensorimotor, isn't it? Play, toddlers. Now, once you go onwards and come back to this question, you're going to understand. The words autonomy and trust are Erickson. Formal operation is Piaget, okay? But formals, they formally can figure it out themselves. That's adolescence. Sensorimotor is all about the young kids. It's all about touch and feel and movement. It's that play, 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 play. Which intervention helps a hospitalized toddler feel a sense of control? I think the hardest kid to take on vacation or to have in a hospital is a toddler. They do not like this whole big change in life. So, in order to make them feel better, it's to put them on those same type of routines. Can we feed them the same foods? Can they have the bath at the same time of day? I mean, is it every night? Is it every morning? Do they put their jammies on when? I mean, these things are so important for usual things. You'll have a toddler that's a lot quieter and a lot happier. Do all children reach developmental milestones at the same age? I had 6 brothers. And I'll tell you what, we're still trying to meet our developmental milestones sometimes. No, no, no. They are all different, unique, and special. Remember, this is a question asked by many parents and say that as long as they're moving forward on the level, they're doing well. Just because he sat up at 8 months doesn't mean your next one has to sit up at 8 months. It could be 9 months. It's okay. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for the infant? So atraumatic, it means I don't want to give them any stress, pain, or discomfort, right? So what do I do? So absolutely, if you give this infant that pacifier and the other thing, have the parents hold them. That's what I promoted because you can switch sides if you have to do both legs, right? But where does the infant feel better? Right here, right? And of course, have another nurse brace the leg to be sure. But yes, that works beautifully, beautifully. Which of the following immunizations is administered to a newborn? What's the first one that we give? Yeah, we give that vitamin K. Yeah, that's one thing we get. But this immunization, as we go along, there's a bunch of immunizations. I'm going to tell you which ones you need to know all about. And because it's a 2-page in your book. All right. Hepatitis B is given usually in the hospital before they go home. Sometimes it's not, it's all about reimbursement and insurance. And that's usually the first visit at the pediatrician, but that's always given at the hospital. Polio, DTaP 2, 4, 6 months, MMR 12 months, and so is polio. The normal heart rate for a neonate is neonate, first 28 days of life. I mentioned it. It's 140 to 160. By the time they're 1 year old, it could be 100, 120. Okay. And as we get older, it goes down slowly. Also, guess what a neonate blood pressure is? 60 over 40. A 1 year old could be 70 over 40, 50. Okay. As we get older, the number gets bigger, bigger. Okay. And also the respiratory rate. It starts higher, that 40 to 60 for that neonate, and then it goes down to an adult, 12 to 20. What is the preferred site to give an injection to an infant? Got to give immunizations. Where are you going to do it? So injections on infants until they're able to walk is the vastus lataris on the upper outer thigh. What they say with infants, yes, we can put the numbing cream on there, make it numb, but after the injections, to bicycle the legs, to move that stuff around, and know that it is common to have a fever after some of these. Absolutely common. And to give the acetaminophen, the 0.4 or whatever the doctor tells that the infant can have. And sometimes putting heat on that also helps, that the redness in the thigh. The death of an infant under 1 year old with no known cause is what? We're going to be looking at risk factors for this next week. And that is Sid's death, yes. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why? Why isn't she looking at the nurse? And again, this is that cultural thing. And, you know, you're going to mess things up and do things wrong. And what I have found out is when I talk to the parent or an older child, you know, and say, well, I just don't know things. Could you tell me? I don't, because I don't want to offend anybody. They absolutely put you in higher respect because you wanted to know. You didn't do it you did it because you didn't understand. And I found asking questions from that older child or the parent is exactly what you need to do. And usually they're not offended by that at all. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why is he saying that? Again, this is another culture. And again, you don't know all the cultures, you just do the best job you can. Which term refers to an individual's life where he or she is more susceptible to positive or negative influences? And that's called the sensitive period. This is times where they can understand certain different things. It's called that sensitive periods, and they're all different times of a child or a person's life. What is characteristic of the pre-operational stage of cognitive development? Again, this is Piaget. It's thinking. It's more than sensoromotor, right? That's initial how we think about working and playing and moving things around. And then it becomes, now I'm thinking a little bit more. So when we get beyond that infant and that toddler stage and we start thinking more, we don't think by ourselves. We can't figure things out. We had to see it first. That's concrete. Concrete, you can touch, you can taste, you can smell it, you can hit it, right? It's there, concrete. So I saw that before, so now I can do the same thing, okay? Not varied, the same thing. That's what that means, and that's Piaget. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? So again, remember, Kohlberg is all about morals. It's all about rights and wrongs. A preschooler understands reward and punishment, which is good or bad and the consequences that are with them. It means, am I going to get a good praise or am I going to get a punishment? Very good. Let's see how you did today. Lenora, good job. Number 2. Raquel, good job, Raquel. Number 1, drum roll, please. We got an H. And a tech and a sim. All right, guys, what I'm going to do is I'll be posting this on both of the announcements, not only for my class, but for the other class too. Hold on a second. There, all of a sudden I left you. I'll be posting this for everybody. You're going to get all the attachments I discussed earlier. Know that anybody during this term, not in my class, can always look at any recording from any week if you want to on my YouTube channel. It's Professor Bogart Pediatric Nursing. Okay, and it's open public. You can go and look. I've got dosage calculation there. Anybody with problems dosage calc, you need to see me, or I need to send you one of my videos because I make it very simple. You should never get a dosage calc problem wrong because I also send you out examples every single exam. So you really, really should do well. And know that I'm here for anybody. And this week, please contact me, leave Professor Gooks alone. Let him have his time that he needs, okay? And I'm here for you all term if you need to. Have a good weekend, a good day, a good week. Go ahead.
Quick question. I heard earlier on our